So I'd like to welcome everybody to Department Medicine Grand Rounds today. Today is a special occasion. It's our Meiklejohn Endowed Lectureship. You see here a picture of Dr. Meiklejohn. So Dr. Gordon Meiklejohn was the founding chair of the Department of Medicine. He came to Denver and to the University of Colorado in 1951. He took a pay cut to come here to an underfunded backwater medical school and Department of Medicine, where you could count the total number of faculty on two hands and still have some fingers left over. We had zero research program and were essentially not on the map. And Dr. Meiklejohn is the person who largely changed that. So over the course of his 25 years, he built all of the divisions and subspecialty divisions that make up our current Department of Medicine. He established the research programs that have since grown into the department we have now. He was a remarkable investigator himself. He was instrumental in the eradication of smallpox and was particularly well known for his role in establishing flu vaccination and the original flu vaccines. He also was known for his warmth and his humanity. He was beloved by his faculty and by students and residents alike, as well as by his family and friends. We're fortunate to have Pat Graves with us today, and Pat worked with him for the last 25 years of his career. So thanks for being here, Pat. And we had members of his family with us yesterday. So anyway, today we remember Dr. Gordon Meiklejohn, and we're fortunate to have today as our Meiklejohn speaker, Dr. Adam Cifu, who's going to be introduced by Dan Pollier.
Well, thanks so much. It's a real honor to be able to introduce Dr. Cifu. Dr. Cifu received his medical degree at Cornell and went on to do residency and chief residency at Beth Israel in Boston. He then came to the University of Chicago, where he has been for many years and has had a really impactful and prolific career. For those of you who don't know Dr. Cifu, he's a really prolific writer and just sort of thinker in the field. You'll hear, I'm sure, about his book, which I would highly recommend to everybody, on ending medical reversal. He also does several podcasts and has a really amazing Substack that I would also recommend subscribing to. So just somebody that has great observations about the work that we do. On a personal level, about 25 years ago, as a second-year medical student at University of Chicago, Dr. Cifu had the misfortune to be assigned to me and my small group for mentorship, where we learned things like physical exam and interviewing patients. He was clearly the lowest ranking member of the faculty at the time to be assigned to this group, which included me, two future orthopedic surgeons and a future neurosurgeon. He had his work cut out for him, but his misfortune was our great fortune. And I really continue to draw on a lot of the skills and things that Dr. Cifu taught us way back then. I'll just share one other personal story and then we'll get to it. Several years after that, as a resident, I was having some pain in my left knee when I was riding the recumbent bike at the gym. And so I said, I'm going to go see the master and I'm going to make an appointment, see Dr. Cifu. He's going to lay hands on me. We're going to figure this out, diagnosis, treatment, the whole thing. So I show up in his clinic and I think he's a little confused to see me and comes in. I probably had my pant leg rolled up. And he said, what's going on? And I said, I'm having some swelling in my left knee when I ride the recumbent bike at the gym. And he just looked at me and he said, stop riding the recumbent bike at the gym. I got patients to see. And I said, oh, okay. And 20 some years later, I've still taken his advice, totally cured. Knee is totally cured, thanks to Dr. Cifu. So thank you for that. And with no further delay, I'd like to introduce my friend and mentor, Dr. Cifu.
I was very worried where that story was going. Thank you so much for having me. I got here on Monday afternoon, spent yesterday, section of general medicine, gave a talk, went out to dinner. learned all about Dr. Mickeljohn, which was a pleasure. Have the book From Slap Shots to Flu Shots to read on my way home, and I felt just welcomed and honored to be here. So first, my great appreciation. I am going to, let me make sure I can just start here. Guys might have to help me out. Forget it. I'm changing here, but not on the screen. Do I have to open a different? I have to switch to. No, just I'll use that.
There you go, Mike.
Next. Okay, good. I like it when it's not obviously fixed immediately to make me feel like a complete idiot. So I'm going to talk today about medical reversal. I'm going to start with my conflicts of interest. My conflicts of interest tend to be both conflicts of interest and advertisements, which I feel terribly guilty about. Dr. Pollier was, I think, did it for me. I do collect royalties for a book about medical reversal, as well as a textbook on diagnostic reasoning and a Substack, which you'll hear about just because I'll reference some things from them, but hopefully it won't seem like advertising. So what is medical reversal? Medical reversal, just as far as a definition, is when a currently accepted practice is overturned. That means that something we are actively doing, with our patients, for our patients, to our patients, is found to be no better than the therapy it replaced, or sometimes found to be no better than no therapy at all. It always occurs because that abandoned practice was adopted based on a insufficient or not a robust evidence base. This is just to sort of bring you through, the different kinds of how we adopt practices. So replacement is the term I like to use for when things go the way they should go, okay? We have an accepted practice. We're happy with what we're doing. Robust data comes out that supports a new practice, and then we adopt that as a superior practice, and we go on, and medicine has advanced, and we're happy about that. What reversal is when we have an accepted practice, and then some new practice is proposed because it has a good story, it sounds like it should work, and there's some sort of data, maybe observational data, maybe small single-center randomized controlled trials, something which makes us say, okay, we should adopt this as a better therapy. But then what happens over time is that more robust evidence comes out that proves to us that that therapy that we've adopted and we've sort of deployed out to our patients is actually not as good as we thought. And actually what we should do is go back to what we'd been using before. I want to just contrast this to what's regular science, okay? What's not reversal? What's not reversal is there's a novel practice. It goes through a study. The study shows that it's not beneficial and we have to go back to the drawing board, right? That's just normal science, the way we want things to go. The difference is that large numbers of patients have been exposed to that outside of trials. So my outline today, I'm going to give an example of medical reversal. I'm going to talk a little bit about research that we've done to try to figure out the frequency of medical reversal. Spoiler, I don't actually know what the frequency of medical reversal is, but I'll tell you what we think. Talk basically with one slide about the harms of reversal, and then go into a selection of the causes of reversal. I could kind of talk for days about the causes of reversal, but I've limited that to a few interesting things, and then I'm happy to answer questions about other causes as we go. So I learned to pause here in the talk when I first started talking about medical reversal, because the first couple of times I gave this talk without this pause, I got a lot of sort of hateful looks as I went through the talk. And this is just to say that we, I think, have all experienced medical reversal. Anybody who's practiced for any amount of time has experienced this. It's something which is actually just sort of a part of medical practice. So I want you to sort of think for a second about, some sort of practice that you had done or adopted in the past, whether it's a medication you prescribed, whether it's a diagnostic test, a procedure you referred to, a procedure that you did, whatever, that you absolutely thought was the right thing to do at the time, and then learned that it in fact was the wrong thing to do. Not that something better came along, but that you really should just go back and do what was being done before, or maybe not treat this problem at all. My practice experience could probably fill up multiple slides. This is just a smattering of them. There are a bunch of medications that I've put people on that in retrospect was the wrong thing at the wrong time, I guess. Procedures that I've referred people to. I'm a general internist, spend most of my time in the outpatient setting, some of my time in the inpatient setting, and certainly some screening tests that I've referred people to, which in retrospect was probably not the right thing to do. I'm going to focus on one, which is an old example, but an example I like because it's kind of dear to my heart, is using atenolol as an antihypertensive. Atenolol was once a very popular antihypertensive. It was kind of a trial standard, meaning that if you came up with a new antihypertensive, you basically had to show that it was, at least as good as atenolol to get it out there in the world. As a fourth-year medical student, we had this kind of stupid project where we had to create our own pharmacopoeia of 20 drugs that we expected to use in our career. And I think atenolol was like number 2 or 3 in my list. So the fall of atenolol began with the LIFE trial way back in 2002. This was just as the ARBs were coming on the market. And the LIFE trial was a beautiful randomized controlled trial, which compared a losartan-based antihypertensive regimen with an atenolol-based antihypertensive regimen. The patients, 9,000 patients, 55 to 80 years old, they all had cardiovascular risk factors, hypertension, and LVH. They were treated for at least 4 years, really robust endpoints here, right? Death, myocardial infarction, or stroke. And the data from the trial, first, it showed that losartan is a really good blood pressure medication, as is atenolol. It lowers your blood pressure, and it lowers it equally. But when we looked at not blood pressure, a surrogate endpoint, but an actual clinical endpoint, the composite endpoint here, we saw that losartan was better. Now, this is not a problem, right? This is a replacement. We had a good drug with atenolol. Now we have a better drug with losartan. See about a 2% absolute risk reduction in the composite endpoint. Number needed to treat around 50. That's all well and good. Maybe we shouldn't use atenolol as first line. Maybe we should go with losartan. Reversal of atenolol came a couple of years later when, sort of inspired by the LIFE trial, some researchers did a meta-analysis where they went back and looked at comparisons of atenolol versus placebo, not looking at blood pressure, but looking at cardiovascular outcomes. And you see here, it turns out though atenolol does lower blood pressure, it doesn't decrease all-cause mortality, doesn't decrease cardiovascular mortality, doesn't decrease MI, maybe slightly on a good day decreases your risk of stroke, but not a whole lot. So this was a medication that was making the numbers look good, but not actually helping people. That was sort of a standard go-to antihypertensive for years. This to say, you don't want to paint all beta blockers with the brush of atenolol. This is a more recent meta-analysis looking at beta blockers as antihypertensives. They're certainly not our first line, but non-atenolol beta blockers do have a positive effect. So how common is reversal, right? So is reversal rare but memorable, which it is, because if you've put a bunch of patients on a medication and then find out that you're not actually helping the patients, that's going to be memorable. But it doesn't really matter if this is, once or twice in a career, or is it common and something that we should be concerned about and maybe work to reduce? So as I mentioned, we don't know, because if you think what you'd have to do to figure out how common it is, you'd have to sort of take everything that we do in medicine. You'd have to look at the evidence base of all of those things. And you'd be like, wow, there's a lot of things here which don't have a robust evidence base. And then you'd have to study all of those, design robust clinical trials of all those. And that would take, multiple careers and, the entire NIH budget to accomplish. And by that time, there'd be a whole new set of medications, so it would be hopeless. So we had to sort of figure out other ways of looking at this. There was some data out there. The first is a article by John Ioannidis from back in 2005, which is an interesting way of looking at a different but related question. And what he did at the time, he started with 45 highly cited works. And these were the kind of works that we all dream of writing, right? These were trials that had already been referenced over 1,000 times. So total like hits in the medical literature. And then he tracked what had happened to those results over the following years. And what he found is that 16% of those interventions were found to be ineffective, okay? So where a highly cited trial said, this is a breakthrough, later research showed not effective. 16% showed less effective than originally thought, less effective than was shown in that original trial. 44% were supported by future literature. So it's like, this is good, we should be doing this. And 24% were never studied again. And so you might say that if you studied that, the breakdown would probably be what the breakdown was in things that had been studied. Now, this doesn't really answer the question of reversal, right? These are not things that are being used frequently out in the public. These are things that are highly cited, in the ivory towers, but still gives you a clue that this is something which doesn't happen once in a career. There was a nice work that was published in the British Medical Journal, because if you have a national healthcare service, you'd like to look after your budget and make sure that what you're doing is actually helpful to people. So the authors here looked at 3,000 of the most commonly done medical interventions, medications, procedures, surgeries, and said, let's just look at the evidence base behind these. And what they found was that 11% were clearly beneficial, robust evidence base. 24% likely to be beneficial, 7% kind of trade-off risks and benefits, things that we do every day in the clinic. But about 8% were probably or definitely ineffective. And that 50% of the things we were doing really didn't have any sort of evidence base that, in the 21st century, we would consider adequate for a medication. And again, maybe if you say, well, if we studied the other 50% here, maybe we'd end up with 16% of things that don't work, and that would certainly be concerning. Our approach to this was to dive into the medical literature and said, so let's look at what happens when we actually study therapies, medical practices that have already been adopted. And so we looked at 10 years of New England Journal articles. There were a ton of articles, 2,044 articles. Fortunately, we only had to look at scientific articles, only had to look at trials. And what we found is that in this large group, there were actually 363 articles that reported the results of studies where a currently used medical practice was tested in a randomized controlled trial. And it turned out that of those 363 articles, 40% of them showed reversal. So 40% of the things that we were doing that we tested turned out to not be effective anymore. 38% were effective. So, okay, we're doing the right thing. Good news. 22% inconclusive. So this is what the breakdown looks like. 2,044 articles to begin with. Good. About 2/3 looked at a medical practice, medical concern. The rest of them were basically basic science articles. This is interesting. This is the studies which looked at a new practice, and you sort of see the breakdown, not really of what happens, but what gets published in the New England Journal. About 77% said the practice was effective. 17% was kind of, back to the drawing board. 6% inconclusive. This, however, was what we were interested in. This is the 27% which looked at a new practice, and you see the results I talked about. 40% of those 40% of those adopted practices, when they're tested, turned out to be ineffective. So this is not looking at everything we do. This is looking at everything we do, but through the sort of lens of what interests the editors at the New England Journal, but is still making you think, okay, this is not rare. We expanded this a couple of years ago by saying, we kind of like this design. Let's just stick with it and make it bigger. And because we'd published a bunch of stuff, it was easier to get research assistants to help us do the work. And so now we looked at JAMA, Lancet for about 20 years. We looked at the New England Journal for 10 years, not an overlapping 10 years. And now we had over 3,000 articles to dive through. And long story short, what we ended up with was about 14% of the randomized controlled trials counted as medical reversals. We were a little bit more careful this time, and we kind of went forward. We looked at meta-analyses of the issues to make sure that, you know, the randomized controlled trial that we were counting as the robust data that reversed to practice wasn't kind of a one-off. We looked at meta-analyses to make sure that meta-analyses supported what we were doing. And in the end, we actually came up with 396 reversals, 6% of all articles, 13% of randomized controlled trials in, you know, 3 of the most major, most influential journals there are. So this certainly sounds like something that's out there in practice that's worth at least thinking about, considering, and talking about how we should reduce it. So what are the harms of reversal? And this is obvious once you think about it, right? First is that patients receive ineffective care. Right? You're giving patients a medication, a procedure, a surgery, using a diagnostic test, which actually doesn't work as well as something else. And the something else may not be anything at all. When you think about, you know, high value care and low value care, there's nothing that's lower value care than something that doesn't work. So this is important. There's an opportunity cost, therefore. The patients are getting this ineffective therapy when they could be getting something else. There's a monetary cost, right? There is absolutely nothing we do in 21st century medicine, which isn't cheap. And then physical harm. Some of the things that we turned up, not only were these therapies ineffective, but they actually harmed patients. There were complications to these interventions, which maybe there's a trade-off of, you know, harm and benefit, but in these practices that there was no benefit, basically all that was left is harm. After reversal, de-adoption takes a long time. Most of the estimates are 5 to 10 years before practice, which has been completely debunked, kind of disappears from the medical literature and guidelines. There's very interesting research that's grown from ours on what predicts the abandonment of practices and who sticks around supporting a practice which has been overturned by a randomized controlled trial. You might guess that there's some money involved in those decisions. And then loss of trust in the medical system, right? Patients don't like to hear that we were wrong and that we've had to go back on our recommendations. And I always joked, I arrived at U of C soon before I met Dan in 1997. It was a time that kind of estrogen replacement therapy was pretty standard for postmenopausal women. I had a little 3-minute spiel about, you really should do this. You know, it's good for your bones. It's not so good for your breasts, but it's really good for your cardiovascular system. So you really should try it. And then a couple of years later, the Women's Health Initiative came out. We were like, maybe not as enthusiastic about estrogen replacement therapy. I had to have those conversations again with those patients. Most of them came off their estrogen replacement therapy. And now many of those women are still my patients. They're, you know, now in their 70s and 80s. And still when I recommend a new medication, they're like, this isn't going to be like estrogen replacement therapy, is it? And I was like, you still remember that. So that's an important lesson. Okay, so why does reversal happen? So most importantly, and this happens again and again and again, if you look at these reversed practices, it starts with sort of our undying faith in, you know, the basic science and mechanistic arguments, in the idea that really things that should work must work, okay? There's a like beautiful story behind, you know, how we're affecting the insulin receptor and how that's gotta be good for people. But the reality is that we are incredibly complicated and our science, you know, is not quite perfect right now. And so many times things that should work don't work when you actually do a trial, try it in real people with complicated lives and other medications and so on and so forth. And then on top of the theory comes some sort of inadequate data. Sometimes there's studies which really anybody would read and say, this isn't really convincing. It's an observational study. It's a poorly controlled trial. It uses surrogate endpoints, which maybe was a reasonable decision, but surrogate endpoints are often not perfect. Sometimes it's just extrapolation. It's, wow, you know, cardiovascular stenting works amazingly in acute MIs. You know, it is gospel. We have to use it. So it must work in people with stable angina, and not always the case. And sometimes it's saying, wow, we know this therapy works in people who are kind of next to death. So it probably works in people who are at home and having mild symptoms. And maybe it works even in people who have preclinical disease. And generally those extrapolations expand the market for the medical intervention that we're using, but you're not guaranteed that it's still helpful in that other population. And then sometimes, which is the thing that I think, kind of most interested now, is that very often we're tricked by what we consider, you know, our gospel, you know, the perfect randomized controlled trial, where there is good data, but for some reason, the randomized controlled trial has sent us in the wrong direction. Randomized controlled trials have error rates. We all know that, right? There's alpha error, there's beta error in the randomized controlled trial. So we should sort of be more comfortable looking at our RCTs as diagnostic tests with, you know, positive and negative likelihood ratios, and recognizing that sometimes a positive randomized controlled trial is just a false positive, and it's not actually true. Early termination of trials that are stopped early for benefit systematically overstate the benefit of the intervention being studied. Single center trials, I'm going to talk a little about. Post-randomization confounding, another thing I'll talk more about. Publication bias, right? We all know that the medical literature is biased towards positive findings, just because of what's accepted, what's funded, you know, what gets submitted after the trial's done. And then evolution. Sometimes something which worked and was supported by robust evidence in the 1980s is no longer as effective in the 2020s when the population has changed greatly, when other therapy that patients would be on has changed greatly. And we'll talk a bit about that. See how I'm doing on time. Okay, so these are my few cause highlights. And every time I put together a reversal talk, it like kills me to narrow these down to, you know, 4 or 5 things. It's like kicking your children out the door. But these are these are 5 that are kind of on my mind recently. So the first is poorly controlled trials of subjective endpoints, okay? So we all know the placebo effect is real, is powerful, right? If you're not using the placebo effect to your patient's benefit and your benefit in your practice, like you're doing something wrong, right? We need to use the placebo effect. But when we're studying things, and we're talking about subjective endpoints, right? We think the placebo effect doesn't really have much of an effect in preventing stroke or death, but it does have a huge effect in helping pain, helping mood, you know, helping energy, things like that, that we need to do a very good job of controlling for our intervention. We're pretty good at this in medical trials, right? We have mastered the placebo-controlled trial, but we're not as good at this with surgeries or procedures or devices, because to control for one of those interventions, you need to have a sham control. That takes a lot more money. It's a lot harder to enroll people in those studies. There are some ethical quandaries about that. But so that means we do it less. But there's a long history of things that we have done and been happy with these interventions until we did a sham trial. And then with the sham control, we're like, you know, it doesn't actually work. The very first one probably was back in 1959. There was an Italian thoracic surgeon who was doing internal mammary artery or internal thoracic artery ligations for intractable angina. And the idea was that maybe if you tied off this other artery in the chest, that pressure would back up and there'd be more pressure going into the coronary arteries and people's angina would get better. And it was working and everybody was getting better. And people were like, this guy's great. And then they did a sham procedure. And so they randomized people actually to the internal mammary ligation or to surgery where they were anesthetized. They had little tiny incisions placed in their upper chest. They had a couple of stitches placed in their upper chest. They woke up and you wouldn't believe it. Those people's angina got better too. So it turns out that's why we don't do that procedure anymore. And then over the last 20 years, I just threw up a sort of bunch of my favorites of some really beautifully designed sham placebo trials that you see here. JAMA, I think recently, there's someone at JAMA who's got a thing out for platelet-rich plasma. There was a time that it seemed like every couple of months they were like, platelet-rich plasma doesn't work for this or this or this or this. I'm not sure what sort of anti-conflict of interest there was going on there. This is just a nice slide. This was a friend of mine from residency, so I feel like I have to put up his study here just to remind everybody of how robust the placebo effect is for symptoms that we wouldn't expect, were affected by placebos. So this is people with asthma, looking at how different interventions help asthma symptoms, okay? And so this first slide is looking at FEV1, and it's seeing how FEV1 responds to an albuterol inhaler, a placebo inhaler, not acupuncture, but sham acupuncture, and just a no intervention control. And not surprisingly, albuterol works and the other one doesn't work. But what if your endpoint is not FEV1, but just control of asthma symptoms? Well, then it turns out that the placebo inhaler and the sham acupuncture work just as well as albuterol. And the only thing that doesn't work is a non-controlled intervention. Maybe even more striking, this is like getting way outside my field, but I just love this study. Responsive cortical stimulation for the treatment of medically intractable partial epilepsy. So I think of this as like ICDs for the brain. These are implantable devices that see a seizure starting and then give a little tiny shock to disrupt that seizure. And these researchers, were just so smart. They got 200 of these patients. These are really sick people. These are people on maximal, anti-epileptic therapy who are still having seizures. They implant this device, but then they only turn on half of them, okay? So they've basically created a sham control. And what's interesting about the results is, first, this actually works. And so these are people with, the worst, most difficult to treat seizures. And look at this, between 1/3 and 40% improvement in their seizures. So, pretty wonderful. But then look at the sham group. The sham group has a placebo effect, okay, on their seizures, or at least what they're reporting as their seizures. And it works exactly like a placebo should affect, right? It has a moderate effect, which diminishes pretty quickly over time, okay? So we can affect a lot of things with good placebo interventions. And so when we do trials, if we want to make sure that a treatment that we're proposing works and is not just an expensive, possibly dangerous placebo intervention, we should make sure that our trials are designed well. Next is reliance on surrogate endpoints. Designing and running studies with clinical endpoints is incredibly difficult. It's incredibly expensive. We cannot do it for everything. And so we rely on surrogate endpoints, right? Stand-ins for the clinical endpoints. Those allow faster, less expensive studies. The surrogates we trust most are those which are most closely linked to the endpoints, right? We all, pray at the altars of hemoglobin A1Cs and blood pressures and bone density, things like that, the patients don't care if their bone density is better. They care that they don't end up with a painful compression fracture. But it turns out that even our most trusted surrogate endpoints sometimes do lead us astray. A bunch of examples here. Maybe the most famous and what people often say, began the evidence-based medicine movement was the CAST trial, where we knew very well that people post-MI in the CCU often died of lethal arrhythmias, ventricular fibrillation. We also knew that the patients most likely to die of an arrhythmia were those who had a lot of PVCs. We also knew that we had medications that could suppress PVCs. And so it was obvious that those medications would not only suppress PVCs, but would save lives. Well, it turns out that when you did a trial, those medications did suppress PVCs, but they also increased mortality. A1C, surrogate endpoint we rely on, but we've had medications which decrease A1C and don't actually help patients. Medications which decrease lipid levels, but probably don't do a whole lot for cardiovascular outcomes. Progression-free survival is something that, the oncologists seem to always be debating. Is progression-free survival an important endpoint, or should we really just be looking at survival and quality of life? Avastin, bevacizumab, is the greatest example of that, approved based on improved progression-free survival for breast cancer, and then take it off the market for that indication when it turned out that it really was not helping. Blood pressure for cardiovascular outcomes, we talked about atenolol. Hospitalization for mortality is a really interesting one, because hospitalization's bad, dying is bad, but sometimes we look at something that decreases hospitalization as sort of a stand-in for saving lives. It turns out that 25% of the time that both hospitalization and mortality is reported in randomized controlled trials, they go in opposite directions. So you may decrease hospitalization, but increase mortality, or increase hospitalizations, but improve mortality. So they're both bad endpoints. You should just look at them both and not look at one as a stand-in for another. Single center studies. So single center studies, again, kind of like surrogate endpoints, we'd love every study to be an international multi-center study, but you just can't do that. And so lots of our studies are, I'm going to do this at my home institution. And so you're doing that single site, single center, but they can be idiosyncratic. You're looking at one group of patients, you're looking at one group of doctors, you're looking at one type of disease. For sort of systems-wide interventions, you often have some sort of, super charismatic leader who's like, I'm really into this, and I get everybody to like adopt my culture. But then when you bring that out to the wider world and you no longer have that one person working for it, maybe it doesn't work as well. Got some examples of single center studies. Gown and glove precautions, right? Every day putting on the yellow gowns and the gloves works amazingly at single centers where you have someone there. I won't name the person at my institution who's, amazing driver of doing this. And, we do better. But then 3 months later, we slip back to what we were doing, and you bring this out to a lot of hospitals and nobody does a very good job. And so it doesn't work anymore. Early sepsis intervention, a little controversial, but, when the Rivers trial was repeated outside of Pittsburgh, maybe not as profound benefits, tight glucose control in the ICU. And there was this wonderful study just last spring, which I just loved. You'll see why. It's sort of like the kind of studies that I do. And this looked at positive single center studies. And then what happened when that same question was tested in a multi-center study? These authors just looked at critically ill patients, and they just looked at mortality as an endpoint, okay? And the way they went after it is they said, okay, we're going to look at studies of critically ill adults. We're going to look at single center studies published in the New England Journal, JAMA, and Lancet that showed a mortality benefit. And then we're going to identify subsequent multi-center randomized controlled trials, which assessed the same question, okay? They found 19 of those single center RCTs. They found that 16 of those 19 questions had been then addressed by multi-center randomized controlled trials, 24 total multi-center randomized controlled trials. And it turned out that only one of the single center studies results stood up in the multi-center study. 14 of them, 88%, actually were followed up with multi-center randomized controlled trials, which then showed no difference. And one of them, actually, the intervention turned out to increase mortality when they looked at a multi-center study. This is the really nice diagram from their study, which sort of outlines those results. And these researchers went a step further, which I thought was really impressive. What they did is they looked at how those single center studies had influenced guidelines, okay? They limited this just to 19 that had been studied. And they found that 14 of the 16 of those had actually influenced international guidelines, okay? So guidelines were based on that finding. Only 6 of the 14 were overturned by the multi-center studies. So there are still, 8 of these out where international guidelines are saying, do this based on a single center study, which we know is wrong based on the multi-center study. And that's part of that reversal takes time to really get incorporated into medicine, right? We don't all have an app which says, wait, stop, don't do this anymore, which beeps as soon as the trial's published. reversal by evolution. This article, to shamelessly self-promote one thing, I think is my favorite article ever, which I did with one of our medical students who's now a neurologist of all things. But this was looking at like, so what about those things that really once worked and we really were doing the right thing, but we're now not doing the right thing just because times have changed. And this is sort of depressing because what it tells us is that even our best evidence should sort of come with an expiration date, right? That there should be some time like, you may be following this, but it probably doesn't work anymore. So you should retest it. And a couple of examples, prophylactic aspirin is a big one. We had the Physicians' Health Study back in the 80s, huge randomized controlled trial. Its main problem was that, it applied to like middle-aged white doctors and nobody else. But, putting that aside, but it turns out that when we've retested that lately, the harms of prophylactic aspirin have stayed exactly the same, but the benefits have decreased because we smoke less, we exercise more, we use more statins, there's less trans fat or no trans fat in our diet anymore. Evolution may happen because an effective medication is no longer effective because the rest of our therapy has just gotten so damn good. There was a brief time in the 2000s where it looked like ACE inhibitors were beneficial in people with vascular disease. It was the HOPE trial. But then just a couple of years later, that study was rerun with all the people with vascular disease appropriately being on statins. And it turned out that the ACE inhibitor benefit was completely washed out by the benefit of statins. And then screening tests. Screening tests work when it's very important to find a disease early. If it doesn't matter when you find the disease because your treatment is so good, then your screening test is not necessary. And instead of screening an entire population, you can treat the relatively small number of people who end up with that disease and they'll still do just as well. Testicular cancer screening is probably a good example of that. When I was in college, everybody was like, you got to do testicular self-examinations. It's so important. And now, nobody talks about testicular self-examinations. And the very last one, post-randomization confounding. This is a really a neat one, which is troublesome because it probably most affects our best trials, okay? What happens here is you do a really nice randomization. So your intervention group and your placebo group are identical except for your planned intervention, okay? But it's a long-term study and it's a pragmatic study. People are out there in the world, living their lives. And so other things happen to them. And if those things happen in an unbalanced way, maybe because of the therapy you've put into play, then your groups are no longer balanced with respect to everything else other than your intervention, okay? And so it may be different meds, it may be different rates of disease screening, it may be differential or loss to follow-up, all sorts of things. Probably the best example, I'll maybe begin and end with estrogen replacement therapy here. So the Women's Health Initiative, which I don't want to say nail in the coffin is too strong, but let's say tempered our enthusiasm for postmenopausal estrogen replacement therapy, did so by demonstrating that if you compared people on estrogen and progesterone to people who got placebo, the hazard ratio for coronary heart disease and stroke was elevated in the estrogen replacement group, okay? The study was run in the late 90s, early 2000s, and that was a period where statins, first studies for statins were, I guess, 1993, were just really picking up in the population. Statin prescribing at the time was driven wholly by your lipid profile. Estrogen replacement therapy improves your lipid profile. That's why we hypothesized that estrogen replacement therapy would be beneficial to prevent coronary disease. And so what happened? Well, it turned out that the placebo group was more apt to be prescribed statins than the estrogen replacement therapy group, right? Because the estrogen replacement therapy group, oh, it looks like their lipids are pretty good. They don't need a statin. This is what it looked like graphically, pretty big difference over the years. And so maybe once you see this, our results in the Women's Health Initiative wasn't because of the harm of estrogen. It was the harm of kind of being protected from being prescribed a statin, which would have benefited you. And you're just left a little more confused. So summary, reversal occurs when accepted practices are overturned. The causes, we have great faith in our science, so we love a good story, how a therapy should work. And then on top of that is inadequate data or randomized controlled trials that just aren't as good as we hope they will be. The take-home message, a percentage which I can't tell you what it is, probably doesn't work, but just one more reason we should be humble, like we need another reason to be humble. And when we prescribe those ineffective therapies, whether we know it or not, we're doing some harm to our patients. And so how can we lessen medical reversal? It seems pathetic to leave this to like the final slide, but mostly it's just committing to practice from a firm evidence base. It's, doing the work yourself. Look at those, why do we do this? Let me look up the studies. Is it that I'm basing my care on an observational study from 1992, in which case maybe I should be concerned about what I'm doing? Or am I, basing it on a, 2018 multinational randomized controlled trial that I've read through and I'm pretty sure is free of bias and I buy the results. We can work to lessen bias in study design, lessen publication bias. And then what I have thought a lot about over my career is, how do we train doctors differently? Well, I think we just have to remember that treatments work because they've been shown, empirically to work, and pull people away from the kind of reductionist basic science, well, it seems like it should work in the lab, so it must work in people. It's tough because, everybody gets accepted to medical school because they did well in sciences. And then when people get to medical school, what's the first thing we do? We bang them over the head for a year or 18 months or 2 years with those basic sciences. And only afterwards kind of come the clinical sciences. And so I think there's a good argument for sort of flipping around medical education to say, you know what, we're going to get to the basic sciences basically after we teach you how to read the medical literature and after we teach you kind of where medical knowledge comes from. So I'll open it up to questions, comments, things that you think you're not buying at all. Got a lot of stuff out there, lots and lots of articles on medical reversal if you're interested in reading further. And I'm happy to talk to people also in any setting going forward. So, thank you.
Well, thank you for a terrific talk, Adam. And we do have some time for questions, and we have hands up immediately. So
that was
is a question,
nice,
a comment, or an attack?
very nice talk. That was great. We'd like to get it right the first time, obviously, and you've provided some very good reasons why we don't always do that. I guess the optimistic view, though, is that as a profession, we continue to test and retest things. And it's so important then that we're completely transparent about the fact that we were wrong the first time. Very good messages. I completely agree. And I'd say that I've also found that input from the FDA, like in the design of trials, is highly valuable. And having a really solid biostatistician involved up front makes a huge difference. Helps us to avoid some of the errors that you pointed out, especially around surrogate endpoints. And
around the surrogate endpoints.
But thank you very much. It was great.
Yeah, I think you're right. I mean, I think as I've matured, even just the 10 years, I've sort of been thinking about this. I've just appreciated how hard it is to get the robust data to begin with, to practice based on that robust data, and then the work it takes to sort of follow it forward. I have other authors, actually interestingly lawyers, an article that I've been reviewing, which really focuses intensely about how we do a better job of the post-approval research, the sort of post-marketing research, the phase 4 trials, whatever you want to call them, and actually sort of figuring out the economics about maybe can we have the payers, the insurance companies, who actually have, a lot of authority in what gets covered and what doesn't, kind of take on a little bit of the role of let's further study these, because to some extent, they're footing the cost of paying for these medications. They should know if these new, more expensive things are definitely more effective. The hard part about those is it always turns out to be non-randomized. So although it's very good for picking up rare adverse effects, it's a lot harder to figure out how to kind of do it for benefit, right? But they're great points. Thank you.
Hi, very thoughtful, thought-provoking
Can you talk a little louder? I can't hear you.
Yeah, very thought-provoking talk. One question I had is, of the reversals that exist, are there certain disease prevalences that are more likely to happen with these reversals? Like you mentioned, quite a few like coronary artery disease things and heart conditions, which affect a lot of people, but I was just curious in terms of the breakdown of reversals.
Yeah, so we do have that data, and actually in the second one that I quoted, the EPO Life one, that actually has the breakdown by specialty. The problem is that the subspecialties that come out as doing the worst with reversal tend to be the ones with the best evidence base, because they're actually studying things. So like, what has, hope there's nobody in the room, I'm gonna piss off. Who has no medical reversals is OBGYN, because they don't study anything, and it's because it's really difficult to study things. I think a field which comes off poorly tends to be orthopedics, because I think orthopedics is as prone to the sort of mechanistic argument for doing things as anything, right? I am looking through this arthroscope. I see a meniscal tear. That is not natural. I should fix that, right? But in fact, we did pretty well for whatever, 50,000 years, with meniscal tears hobbling for a month and then being okay. And so a lot of those orthopedic interventions, when you actually test them, they either don't prove to be beneficial, or they prove to be beneficial in the short term, but not in the long term.
Cool, thanks.
It's a good question.
Thanks so much for your talk. I was sort of wondering, as the field moves into this arena.
Do a little louder.
Oh yeah, sorry. Thank you so much for your talk. I was sort of thinking, as the field moves more into this realm of like personalized medicine, where we take people's demographics, life experiences, genetics into account.
Yeah.
How do you think that's going to affect reversal?
Yeah, so I think that's a great question, and I'm not sure I can answer it well, because I think in the ideal world, well, we take a step back. Like that's coming, right? So we can already sort of look at people's profile, or those people who have a profile of pharmacogenetics, and say, instead of choosing blindly, this is actually going to be more likely to be a better antihypertensive for this person than this. The problem is you still need endpoint data for most of those things. And it might be that personalized medicine makes things even more complicated, because you have sort of, instead of saying, I'm going to look at all hypertensive patients and say, I'm just going to do an all-hat trial and I'm going to know the answer. Maybe what you end up with is 50 different kinds of hypertensive patients. And do you actually need a trial in each of those, individual genomes to know what's better? So although I have great hope for genomic medicine, I'm not that optimistic that's going to help the reversal problem. Yeah.
Thank you so much.
Adam, a great talk, and really it got me thinking about a lot of things that I do myself in practice today. One of the questions I have, you remind me that one RCT does not a practice make.
Right.
One guideline does not necessarily be the go-to for everything. But the question I have is, when we know things don't work, we still do them.
Yeah.
So what, have you looked at the phenomenon of how you actually de-implement or actually get people to stop doing things that we know that there's good data for reversal, but it hasn't quite happened yet?
Yeah, I have not. The few things, so the things that work against us de-adopting, right, is that often, and I'll just take full, often we as doctors, we're trying to do the right thing. We've seen people benefit from therapy, right? I've sent people with spinal stenosis for an epidural steroid injection, and 6 weeks later, they were better. And so I think it works, even though I know the data says it doesn't work, right? So that makes it hard to de-adopt. I'm a general internist. I don't make any money. But if you're bringing people to the OR and doing arthroscopic surgery, and you just bought your boat with that, it's hard to believe that that's actually not effective. And then there's this really cool trial that I think I might have, I tend to try to keep some leftover slides in the back, that another group did that looked at the response of subspecialty groups and just, generalist journals at their response to articles that showed reversal. And not surprisingly, the generalist journals were like, oh, well, this doesn't work anymore. We should stop doing this. The subspecialty journals and the subspecialty societies were like, we need a lot more information here. And so I think there are a lot of forces, but it's probably a great area to research. And the data's sort of there, right?
Thank you for a great talk. I just want to look at what you said from a different lens, that on average, we all know that it takes more than 15 years, 17 years, they say, to implement what we find from evidence in practice. And all of the benefit that sometimes we find from the clinical trials, they don't even go to clinical practice or they go like a couple of decades later. I'm just worried that being so nervous or worried about reversal might even delay further, and we might hurt our patient even further by not implementing what we find from evidence of clinical trial and implement it in practice.
You're more of a pessimist than me, because you could argue that you got to do the trial. It's positive, it's unlikely to be positive. When it is positive, you got to implement it. By the time you've implemented it, well, then probably things have evolved so much that the treatment's no longer beneficial, right? I mean, my answer is going to be so obvious to you, but medicine's really hard. It's the reason we have to use our sort of biomedical smarts to some extent too. Anybody who tells you do nothing that's not supported by a randomized controlled trial, is not a doctor, right? It's just, I think it's being skeptical enough. And then what I sort of pitch is when I'm discussing interventions with a patient, I can say, listen, you've had an MI, you're hypertensive, you really should be on a statin, and not doing it is a mistake. Of course, you can do whatever you want, but it would be a mistake. While other interventions, I'm like, look, this is why I think this will work. There's data that kind of supports this, but it's not a slam dunk. It's up to you. And I kind of use that in my counseling, and I try to be, as transparent and humble and honest as I can be. I feel like that's maybe the best we can do. I don't know. It's kind of a weak answer, I understand.
Well, we are right up on the hour. Thank you for a very provocative talk.